Good morning, everyone. In this time, I will present to you a study about the learning curve of laparoscopic ablation of liver tumors. So, laparoscopic thermal ablation is an increasingly used technique for the treatment of colorectal liver metastases and hepatocellular carcinomas. Laparoscopic ablation can be performed either as a standalone procedure for lesions not amenable for percutaneous ablation, or in combination with other abdominal procedures such as liver resection or colorectal surgery. However, laparoscopic ablation is a technically demanding procedure due to the difficulties of laparoscopic intraoperative ultrasound, to a different spatial arrangement compared to open ablation, and to the limitations of needle movement. Such difficulties are often underestimated since laparoscopic ablation is a quick procedure employed for small-sized tumors and with few complications compared to liver resection. Given this background, the aim of this study was to characterize the learning curve of laparoscopic ablations. For this aim, we consider all consecutive laparoscopic ablation procedures performed at Ghent University Hospital since the adoption of this technique. The procedures were all performed by the same surgeon. A lesion-based analysis was conducted since each lesion ablation is a learning moment and each lesion ablation has its own difficulties according to lesion size and position. The occurrence of incomplete ablation was used as the endpoint for learning curve estimation. Risk-adjusted QSUM analysis was used to characterize the learning curve. In this analysis, all procedures are plotted in a chronological order from left to right. For each failure, the line moves up, while for each success, the line moves down. The amplitude of each line movement is inversely proportional to the risk of failure, which is estimated through a logistic regression model based on lesion characteristics associated with the probability of failure. Line breakpoints corresponding to a significant change in surgical performance were identified using broken line modeling. Over a 10-year period, 169 procedures, including the laparoscopic ablation, were performed. The majority of laparoscopic ablation were performed as standalone procedures, while 40% of them were performed on cirrhotic livers. Microwave ablation was the most used technology, and in more than the half of the procedures, only one lesion was ablated. In total, during these procedures, 241 lesions were ablated. The majority of lesions were colorectal liver metastases with an equal distribution between anterior and posterior superior liver segments. The median size was 16 millimeters, and only 15% of lesions had a size above 3 centimeters. At multivariable analysis, the presence of liver cirrhosis, the position in the posterior superior segment, and lesion size above 3 centimeters were all risk factors for incomplete ablation. Therefore, the risk of incomplete ablation was estimated according to a multivariable logistic regression model, taking into account these three parameters. Case numbers was also a risk factor for incomplete ablation, with the risk decreasing with increasing the case number. This confirmed the improving with time the existence of a learning curve. The risk-adjusted QSUM analysis showed the presence of a breakpoint at 93 lesion ablations, indicating a significant improvement in outcomes only after performing such high number of procedures. Comparing the two phases before and after this breakpoint, we observe a significant decrease in the occurrence of incomplete ablations, while the occurrence of ablation-specific complications remains stable. Overall, although some difference could be observed in the lesion characteristic, the overall baseline risk for incomplete ablation remains steady, meaning that the observed improvements were not due to a case selection over the time. Interestingly, when comparing the QSUM curve of laparoscopic ablation with that of open surgical ablation performing during the same time period, we observe that no breakpoint could be identified in the curve of open ablation. This indicates that proficiency in open surgical ablation was already present when laparoscopic ablation were started. Despite this, a significant learning period was needed to master laparoscopic ablation. This confirmed that laparoscopic ablation have their own specific difficulties compared to open surgical ablation. So the learning point to this study highlights that lesions in posterior superior segments and on cirrhotic livers are the most difficult to treat with laparoscopic ablation. Therefore, we can say that what is difficult for laparoscopic resection is also difficult for laparoscopic ablation, and we should not use laparoscopic ablation as a shortcut. Novices should use a stepwise approach when approaching first anterior lesion on fibrotic livers and then moving to lesion in posterior superior segment on cirrhotic livers. At the beginning, expert supervision is needed for such procedures, as well as dedicated training programs and models. Of course, this study has some limitation. No measures of procedural task efficiency, such as the time needed for lesion targeting and number of attempts, could be taken into account, since they were not available at retrospective analysis. Also, this learning curve represents that of one single surgeon, rather than the mean learning curve of a multitude of surgeons. Furthermore, this surgeon was self-taught, and there was no dedicated training or expert supervision, which could have shortened the learning curve. However, the study has several strengths points, since this learning curve is based on a measure of quality assurance, which represents an ecological outcome. Also, the learning curve was analyzed using specific QSUM analysis and was adjusted for the risk of incomplete ablation, which could be possible using a lesion-based approach. In conclusion, so proficiency for laparoscopic ablation requires completion of a step learning curve. Laparoscopic ablation has specific additional difficulties compared to open ablation. Dedicated training and expert supervision is necessary when embarking laparoscopic ablation in order to shorten the learning curve and maximize surgical outcome. Thank you for your attention.